I'm not the house of cards that falls down easily. I'm strong enough to handle what you throw at me.
Welcome to Mental Health News Radio. I'm your host, Kristin Walker. Just what are we going to discuss? The intimacy that is mental health. Let's continue to make it as comfortable as discussing brain health or heart health. This show has been on the air for several years and we have amazing co-hosts. And then we created a network of podcasters on mentalhealthnewsradionetwork.com, a place where every possible facet of mental well-being can be talked about openly. My show, after several hundred interviews, the format is this: intimate, deep, funny, touching, sometimes uncomfortable, but always vulnerable conversations with interesting people. The goal is to have you, our listening family, many of you who have become my good friends, feel as though you are listening in on private conversations. Thank you for tuning in and becoming part of this amazing journey with me, and now with our network of podcasters. Just knowing this podcast might be helping any of you realize you are not alone on this journey called being a human being makes doing this podcast worth every second.
After all, we promised we'd be cordial.
Our guest today, Dr. Omar Manejwala, is one of the incredible presenters at this year's National Council for Behavioral Health Conference held April 23rd through 25th at the Gaylord National Resort and Convention Center in Washington, D.C. Go to thenationalcouncil.org and make it a priority to attend this conference. We'll be there, Mental Health News Radio, broadcasting live and doing pre-conference interviews. Our guest today discusses some of his presentation, but also takes a daring walk with us and in his career to talk about how disrupting the addiction treatment field is vital, the importance of continuing our focus on alcohol addiction, as well as the current opioid addiction crisis. As one of the nation's leading experts on addiction medicine, substance abuse, and mental illness, you don't want to miss his presentation nor this discussion. Thanks for joining us. Good morning, everyone. This is Kristin Walker. I'm here as I gave you our lovely pre-intro of Dr. Omar Manejwala. Thank you so much, Dr. Manejwala, for coming on the show.
Oh, thank you. It's really a pleasure to be here with you, Kristin, this morning.
Absolutely. Now, I've let everyone know that you're one of the speakers at this year's National Council for Behavioral Health, and I love your topic, and I love that we had our pre-show conversation talking about some of the things that maybe some people don't really want to discuss on the air, and that you're perfectly willing to do that.
Yeah, I've never shied away from controversy, so that makes for a fun podcast, I'm sure.
And it's talking about what's really going on, and that is what people need to hear about because, go ahead and repeat for our listeners what you said about the World Health Organization, since they're an organization we'll be working with.
That's right. So, there are a lot of conditions in the world that are subject to stigma. And you could think about HIV, AIDS, a bunch of other infectious diseases. But what's really, I think, accurate, but a testament to the importance of this topic, the World Health Organization recently declared that substance use disorders are the most stigmatized condition in the world. And the most means the most. So nothing is more stigmatized than addictive disorders. And I think that's accurate and it's important, but it also indicates that there hopefully is a shift in looking very seriously at the impact of stigma on these conditions.
Absolutely. So the World Health Organization making a statement like this about addiction and the stigma surrounding it, they have the numbers to back up, obviously, those findings. And it helps people, I think, in the United States understand that, yes, there's a crisis here, but this is a crisis all over the globe. I think knowing that and making those kind of statements helps us here. Many of us can be in this bubble in the United States. I think that helps broaden our eyes to the fact that this is a global problem. It's not just us.
Yeah, and I would just add, that's absolutely true. And I would add to that stigma isn't just uncomfortable, but there's a real human cost associated with that. People who experience stigma are less likely to attend treatment. They're less likely to be referred for treatment, and that has economic costs, social costs. There are medical implications to that. So stigma results not just in illness, but there are people who are actually dying because of stigma. So it's really important that we address this.
Exactly. People are actually dying because of stigma. That's such an important sentence. Let's talk a little bit about that stigma piece. Why is this such a goal for you to talk about the eradication of stigma?
Well, and I know you've talked about this concept before on your podcast, but the vast majority of people who have substance use disorders not only haven't gotten treatment, but according to current trends, and even the latest with investments in addiction and parity and affordable care, the vast majority of people with substance use disorders will never receive treatment for those conditions. And so, by the way, there's no other condition like that in America or really in the world, but especially in America. If you look at diabetes, congestive heart failure, COPD, cancer, and any major chronic diseases, or even most acute diseases and illnesses, there's really no correlation. Even if you look at other behavioral health conditions like depression or anxiety or schizophrenia, there's really nothing else where the vast majority of people have not and will not receive treatment for their conditions. And stigma plays a large role in that. It's not the only driver, but it's a huge driver of that. And we have to fix that. That's not okay.
No, it isn't. Talk to us about your book called Craving, Why We Can't Seem to Get Enough. What was the impetus for you writing that particular book?
Now, that's kind of a funny story because I never thought of myself as an author. I never wanted to write a book. And this whole process began sometime in, I'll say about 5 or 6 years ago, when I was looking for a book on craving. And I thought, well, craving is a universal phenomenon. It occurs in all substance use disorders and also in gambling addiction, but it's also something that people experience who don't have addiction. Everybody craves at some point or another. Surely there has to be a book on craving. And I worked with a librarian who I had used professionally at various times, and we did some deep digging and found that, lo and behold, no one had actually written a book on craving. So that was surprising to me, and I wanted to learn as much as I could about craving. At that time, craving was not a key symptom of substance use disorders in what was called DSM-4, which was the kind of the Bible, if you will, of classifying behavioral health conditions. And then later on, it was introduced as a hallmark symptom in DSM-5, which was good news for a guy who had just written a book on craving. But
good timing.
I mean, right, the timing. Now, it's really amazing, however, that in all these years we never really included craving, which is a core feature of substance use disorders. But so I was looking for a book and couldn't find one. So I thought, well, I don't know if I'll write a book, but I am going to have to go to all the original literature to learn about craving. I was already an addiction expert, but I wanted to do a deeper dive here. And so I read basically, let's just say, everything that's ever been published scientifically on craving. And I contacted the majority of living authors of those research studies. And they were very generous and spent their time explaining their research to me, et cetera. And so I spent I just went into a deep dive trying to understand this thing. And along the way, it just became clear, well, I don't want somebody else to have to repeat all this work. And plus, much of this is not in simple, understandable English. And that's, I'm not good at a lot of things, but one thing I think I'm good at is translating really complicated scientific mumbo jumbo and research into plain English. And so that's what I did with the book, which was really take everything we know about craving at that time and digest it in a way that makes sense both to professionals and scholars and treating professionals, but also to patients and their families, or just anybody who has an interest in this universal human phenomenon. And that's why I wrote Craving.
Now, that's a perfect segue into what I'm going to ask you next. So many people that I've interviewed, including patients, people with addiction issues, and not necessarily in their mind, when they hear substance use disorder, they're not equating things like addiction to food, addiction to toxic relationships, other addictions outside of drug, alcohol addiction. So because you're able to take things, complex terms, and bring them into statements that people can understand, how would you define craving in terms of all of the addictions that we as human beings can succumb to?
So this was another challenge I faced when I was writing the book, because I looked for a definition of craving, and people didn't really agree on a definition of craving. And so one definition which I really liked was, something that you want so badly that when you don't have it, it produces emotional or physical or mental discomfort. And I thought that was a nice definition. But there's another way of looking at craving which I also really like, and this was the basis of introducing craving into DSM-5, which was this question: have you ever wanted something so much that you couldn't think of anything else? And I think that's a great functional definition, because while you're craving something, you can't really think of anything else. So all of the strategies out there for managing cravings that say, okay, if you're craving chocolate, go eat kale. That's never going to work. I mean, that might work I'm not saying don't eat kale, but I'm just saying that for people who are really in the midst of their craving,
right,
those types of strategies are just never going to be enough. And so what I discovered when I wrote the book is that, like many things, recovery from cravings and addressing cravings is 95% about what you start doing, really only about 5% what you stop doing. And just like when the time to fix your roof is when it's not raining, I mean, the time to address cravings is when you're not craving. Obviously, you need emergency strategies too, but I think a lot of the approaches out there that exist to managing cravings really focus on intervening on the craving itself while you're having it. And I think that's very sad, because as most people, I'm sure you've interviewed many, many people in recovery, and one thing that's pretty universal about people who recover from any kind of condition is that they will tell you that this is really about what you start doing and only a little bit about what you need to stop doing. It's a very active process, is I guess what I'm saying.
Absolutely.
Yeah.
So we've let everyone know that you're speaking at National Council for Behavioral Health. While you're there doing your talk, give our listeners an idea of what the talk is going to be about.
Sure. Well, Linda Rosenberg reached out to me, and I know your listeners are familiar with her since you've done interviews with her as well. She's amazing, by the way.
Yes.
Love her. And she reached out, and I think that someone had maybe heard one of my keynotes, or I give 20 or 30 talks a year. I try to limit it. But I think maybe someone had heard one of those or written one of the pieces I had published and reached out to her. And so she approached me and she said, we've got this opioid crisis, everybody's focusing on it, but what about alcohol? I've just noticed over the last few years, most of my media appearances have been about the opioid epidemic. And it used to be that CNN and the other sort of networks would reach out when a celebrity died, and then things shifted over the last few years, and they'd reach out just to talk about the opioid epidemic, the opioid overdose crisis. And of course, as addiction experts, we're just delighted that any aspect of addiction is being focused on. But the whole time, we're really all thinking, well, you do realize that alcohol kills at least 3 times as many people as opioids every year. It just doesn't seem to be killing the right people, unfortunately. And, one of the big challenges there is that alcohol often kills more slowly over a longer period of time. People are often older, and then the other aspect of it is because it's occurring over such a long period of time, it appears like people are making a choice. So it seems like someone is choosing this life, as if anyone would really choose this. But so I think there are a lot of things that conspire to put alcohol in the background. But nevertheless, it's certainly the most costly. By far, it's the most costly. Plus, it's the most lethal, and it's one for which we have treatments available, and we've been treating it for a very long time. So it is very sad. So I thought that it was really it represented great insight and vision on the part of Linda Rosenberg to say, hey, let's make sure we focus on this. And of course, I
Good.
was delighted to do it. So
Interesting question for you about this topic specifically. So, do you think because of that you can actually, and please understand listeners when I say this, but there are people that are high functioning alcoholics, and they can live a very long time, and they can be extremely high functioning. You cannot be a high functioning opioid addict.
yeah, it turns out that you can. You can be a high five. So I think that that's
Okay.
something that people don't know. I spent the first few years of my addiction treatment career treating physicians who were dependent on various substances, including opioids. And we had physicians who were dependent on opioids for 5 years, 10 years, 15 years even before they presented for their first treatment. I think your observation is on point in the sense that now with fentanyl and
Right.
especially illicitly manufactured fentanyl and more IV use, that the progression of the illness tends to be more rapid and presentation occurs rapidly. But we still, even to this day, we see people with really, really long histories of opioids, but they don't make it to the front page, I think, in a lot of ways. But so we see quote unquote high functioning, and I think you're right to put that disclaimer in, because when you really get to know the wives and children of or husbands or significant others or other people close, they will often say, yeah, sure, they may function occupationally, but it would really be a lie to call these relationships functional.
Absolutely.
But and I think that's what you mean when you give that disclaimer. But yeah, no, we do see it with both. I do think really that some of it has to do with race, and with because the crisis, at least initially, was disproportionately affecting young white, especially in many ways suburban and rural. We did not. We were paying closer attention to it, and there are real racial biases in how we talk about this. When it was primarily African American with crack cocaine, we called it a drug war. Now we call it a crisis.
Right.
An entire concept, which was a lie, called crack babies. So there's huge bias and racial tones in what we choose to pay attention to as well, which is very sad.
Very true. Very true. Well, I'm the former spouse of a. Might say he had a 40-year addiction to opioids, started in high school.
Also,
Oh yeah, I lived it, and no, he was not functional at home. But the friends of mine whose spouses or they themselves were addicted to, quote unquote, only alcohol, had a different experience than I did. In terms of functionality with my wonderful ex-husband. So, it's interesting, but you're right. The addition of fentanyl and what's going on with that is the death rate is so much more front page newsworthy. Not that I'm saying that I'm giving it any sort of sparkle because of that statement, but there's a whole different connotation to it. When you add that piece to this part of addiction.
No, exactly. I mean, it's about what we pay attention to. And I really do emphasize, as addiction experts, we've been waiting so long for anyone to listen to anything that, and that's why there's so many people who will say, and I've heard this directly from leadership within addiction organizations, we have to, quote unquote, use this to gain traction for the other interventions that are out there. And that's fine. I have no qualms about that. But I will tell you that I think it's insightful and visionary that National Council wants to focus on alcohol use disorders at this conference as well. And I'm honored to give a talk on it for them. I'm not doing a workshop, but I will be doing a book signing right after the talk.
Gotcha. Well, I doubt we'll bump into each other. I'll be in the media room, but if I do see you.
I look forward.
So my last question for you, because we have so many listeners that are mental health providers. They're either, in school, or they're already practicing, or they're doing their clinical trials. I mean, they're at various stages of their career with their choice being to move into the mental health field. So they always want to know, with a listener that's obviously chosen this as a career. Why this? Was there a personal reason why this was a career choice for you?
So I never set out to be an addiction expert. And like most experts who I respect in various fields, it's really my patients and their families who taught me the most. And then I would follow that up with nurses and then ultimately other physicians and the literature, because what ended up happening for me was I was working in Charlotte, North Carolina, and there were no addiction doctors, so people just started sending cases to me, and I acquiesced and reluctantly started treating folks who had substance use disorders. And then it grew up into a full-blown practice of substance use disorders. So I thought, well, I probably should go get specialized in this. So I went through the ASAM path. But that's how it happened. And what really happened for me is that what I originally thought was a hope, even being a psychiatrist, it was easy to see things this way because my primary observation of people with addictions was in the emergency room. So what I saw and learned in residency was the hopelessness, but what I saw when working directly one-on-one and with the families and applying, the best practices was hope and recovery. And that was transformative for me and launched a career in this space. And that, that leads us to this moment where I'm about to give a talk, on alcohol.
Yeah, and let's talk. Let's have this be. Have this be a closing for today's show. There are a lot of changes in the treatment center industry. Some of them are, more regulated now, which is fantastic. But there are still issues with how people are receiving treatment. How are you seeing this from your side of the street in terms of how the treatment industry, because it is an industry and people seem to forget the business that goes behind it. How are you seeing that change for good or for bad?
So, I'm a little less hopeful about the industry itself. I feel like it's the fox guarding the hen house.
Yes.
And even any sort of ethical principles that have emerged, including some recent ethical position statements that have been put out by industry trade groups, have been developed largely by themselves without multiple stakeholder input. So I really feel like it's the fox guarding the hen house. And, much like I think with bookstores that were disrupted by Amazon or the taxi industry that was disrupted by Uber, I think the addiction industry, and I'll talk about this in my talk, is ripe for disruption because there's a lack of transparency. The purchaser of services doesn't understand what they're getting. They can't compare it. There are no standardized outcomes. It's not efficient or cost effective. There's really not a solid evidence base about matching treatment approaches with the different types of conditions and categories that we face. And so anytime you have this kind of insulated, self-regulating, highly dysfunctional environment, someone's going to come along and say, hey, there's value being lost here, let's make it better. And so I've sort of dedicated the recent 5 or 6 years of my life to fixing this, solving this problem, not by trying to fix the addiction treatment industry, but rather simply trying to disrupt the care and offer alternative models that deliver value and evidence-based treatment by kind of sidestepping the problem. I think we're going to see that. We're going to see the collapse of a lot of these approaches and the replacement by a disruptive model, just like we have in other areas of medicine and in other areas of industry. And with the iPhone, the iPod was not the first digital player; it was just the first one to get it right. And similarly, we're going to see that kind of disruption in the future of addiction treatment as well.
And I think what we're going to see, it's been interesting for me to be on the interviewer side of things. Yes, there's a lot that's going on in terms of the business side of things, but what I see in our kind of narcissistic, social media obsessed culture is that there are a lot of beginners on their own journey of addiction. Really, not that I'm please don't misinterpret any of our listeners that, if you only have 5 years of sobriety, you have nothing to say. That is not at all the case that I'm making here. But what I am saying is that what we see often is people early in sobriety trying to be those disruptors, and really they have just changed from being addicted to a substance to trying to be addicted to fame by making a lot of noise system noise out there in this recovery effort, and they actually don't have the training to back up some of their statements. And they're really looking at this as a ticket to get some kind of celebrity status out there. We see that a lot, and that's been disturbing for us as well. So what is your take on that?
Well, I think a couple of things. Number one is we don't know where the next major disruption is going to come from, and
Right.
it might actually come from someone like that.
Right.
I don't know. I mean, I believe we're creating it, or what in the work that I'm doing now. But I will tell you this, and that is that the system itself is broken, so it needs to be broken further before it can be fixed, and that's
True.
going to be
Good
very,
point.
very, very uncomfortable for a lot of folks. And yeah, I think that at the end of the day, it's going to be largely about passion, integrity, values, and creativity that are going to be the drivers of this, even more so than experience. And I say that as someone who has quite a bit of experience, but I don't lean on that, because I think that at the end of the day, fixing this requires much more creativity than experience.
Good point. Good point. Well,
Yeah.
thank you, because we've had a lot of emails about that. The statement I just made,
Sure.
was very angry, and I thought, well, that'll be it'll be interesting to watch how all of this unfolds, because the end goal here is to help treat this disease that is
Exactly.
on all fronts.
Exactly.
Well, Dr. Manejwala, thank you so much for coming on the show. I hope that we get a chance to bump into each other amongst the sea of, 5,000 to
Absolutely.
7,000 people that will be at NatCon this year.
Yeah, it's a big audience. Yeah.
But please tell our listeners, outside of National Council, where can they find more information about you?
Sure. Well, I'm the Chief Medical Officer of CATASYS, which is CATASYS, and we're transforming how behavioral health care is delivered. But to learn more about me personally, you could go to manejwala.com, which is MANEJWALA.com.
Wonderful. Well, thank you so much for coming on, and have a wonderful rest of your afternoon.
You too. Thank you.
And thanks to our listeners for another edition of Mental Health News Radio.
Without good intentions, I heat up and act on my emotions.
Thanks so much for listening to Mental Health News Radio. Our podcast can be found on iTunes, Stitcher, and hundreds of other podcast apps. Or you can visit our website at mentalhealthnewsradio.com. If you have a question or would like to be a guest, become a podcaster on our network, or join the amazing organizations that help keep us on the air, please email us at info@mhnrnetwork.com. Get ready for that special goodbye from our resident therapy dog, Miles, and a special thanks to Emily Sohn for letting us use her incredible song, Cordial, for our podcast music. Listen to the full song on SoundCloud at emily.sonne.
Don't be surprised when I don't hate on you. After all, we promised we'd be cordial. Sometimes in you I can fight it.
Good boy.